Yes, and here is your timer. This is your question. Right, so if you have read and understood, considering a communication skills patient, kindly begin.
Hi, my name is Dr. Prabjeet Singh. May I know your name and age?
My name is Mrs. Rami, 40 years. Yes.
Thank you. Thank you so much, Sami. Mrs. Sami.
Mrs. Sami, please.
Hello. Yeah.
Yeah, please.
Hi. Yeah, Mrs. Sami. First of all, I would like to apologize that we could not contact you earlier, and your child has been brought here. I could not explain what was going on. First of all, accept my apologies for that.
Okay, what happened right now?
Yeah, would you like to get a seat? Would you like to sit first? Or
Yes.
Need something?
Yes, please. You can continue.
Okay.
Please tell me what has happened to my child, please.
Yeah, I'm coming to that, Mrs. Sami. So as I said that we could not contact you earlier, your child was brought, I'm so sorry to tell you, in a little serious condition. He fell off from a height, and it's not a good news for you right now. Do you want somebody by your side?
No, doctor, that's all right. Please tell me what has happened right now.
Yeah, Mrs. Sami. So after we ran the scans, your child got some injury in the tummy, and we ran scans, and we came to know that he has injured himself a little bit seriously, for which he is now been taken up for an operation.
What operation, doctor? What you're talking? What scan? What operation?
Yeah. So what happened exactly was, when we ran the scan, we came to know that there was injury to one of the organ, which is very vital or important organ in the tummy, called spleen. He has injured that, and there is some bleeding in that organ, for which he had to be taken up for an emergency surgery, and he is currently in the operation theater.
Is it a serious condition? What is spleen? What is this all about, doctor? I'm not understanding. I want to see my son.
Yeah, Mrs. Sami. So yes, this is actually, I'm so sorry to tell you, but really a very serious condition. That's why he's been taken up for the surgery. Spleen is basically an organ in the tummy on the upper left side, and which is important in the defense mechanism, basically. And we have to stop the bleeding, and for that, a tummy has to be operated. He is in safe hands right now, and he is with very experienced surgeons, and surgery is currently going on.
Oh, can you see him now?
I'm so sorry, Mrs. Sami, but he's in, as I said, that he is in the operation theater, and we really don't want to disturb the surgeons. And sorry to tell you that you have to see your son only after the operate is over.
Oh,
I'm so sorry.
What did his father has told you about?
Yeah, his father brought.
Drunk?
Yeah, he is drunk, and he brought him, and he told us that he fell off in the school from swings. After that, he brought him here. And yes, as you said, that he also has a drinking problem and he was drunk. We have to involve the child protection services so that your child is in the best hands. But that all will be done with the proper consultancy with a child protection consultant, and they will meet you later on. And I'll let you meet with the consultant surgeon also after once the operate is over. Anything else I can help you right now with?
What are the medications will be required for this operation, and when can I take him back home? How long the operation is going on? I need to know about this, doctor.
Yeah, so he may need a splenectomy, which is an operation where this organ has to be removed. In that case, there are certain infections which can happen later on, and if the spleen is to be removed, then he will need a vaccination against some infections, and he may be on antibiotics for lifelong.
Lifelong? What
Yes.
you're talking, doctor?
I'm sorry to tell.
Yeah. Lifelong.
Yeah, because this organ is actually important in the control of infections. So if this organ won't be there, then he may need. We have to consult with obviously the consultant in charge, and we'll arrange another meeting and we'll tell you in detail. But he may need antibiotics for lifelong so that he get protected from infections.
Oh, no, I'm so afraid.
I'm so
doctor.
sorry.
Do
you need water?
You can have a look and tell me.
Actually, it is not a good idea to disturb the surgeon right now, because it will only hamper the surgery. I won't really like to go to the operation theater. So it's better if we let the surgery to be completed first.
Okay, when can I take him back home?
Mrs. Sami, actually, he can be taken only when he gets stable. We have to do proper examination. And once we are really, we know that he is okay to go home and he is in stable condition, then only you can take. And we also have to make sure that he is good at home, because as you said, his father is drunk. So I'm sorry to tell you, but I have to share this information with the other colleagues, which are responsible to take care of the child in these cases.
Okay, doctor. All right.
Yeah.
Thank you.
Anything else I can help you with?
No, doctor, I'm fine. Thank you.
Thank you so much, Mrs. Sami.
Okay, how would you close your consultation?
So, Mrs. Sami, I would like to summarize what I have told you already. So I told you that your child was brought after an injury when he fell off from a swing. He was brought by his father, which apparently is who is apparently drunk, and he has got an injury to a vital organ in the tummy called spleen, and he's being operated right now. And you can meet him later on. And we have to involve the child protection services. Is that okay? Do you understand all that?
Well, doctor, yes, thank you.
And
thank
you're
you so
leaving
much.
your number with the nursing staff?
With the we are here to help you out, and I'll leave my number in case you need any other help or you need to consult with something else. You can consult me at any time.
Good.
Okay, doctor.
Thank you.
You still had few seconds left, but it was very good. 35, 6 seconds was still left. So you covered it well within given time. It was very good.
Thank you.
Firm, focused, well aware of the situation, calm. Right, yeah. All these were positive things were there. A good communication went ahead between you and the patient's relative. Right.
Thank you.
It was very good. Few things at the
Please.
end. Yes, now well went. What to improve, right? That's why we are practicing. Once you're 99 or once you're 99.9% perfect, even 0.1% is there to improve.
Yes.
And that's what we would discuss now. Right, you confirmed in the beginning, you greeted, okay, you introduced yourself, you confirmed the name of the relative, but you forgot to confirm the relation of the person, yeah,
yes,
with the child. So you'll say, yes, are you Smith's mother, or can I confirm, can I know how you know whatever is the name of the child.
So do you think ma'am, in these kind of scenarios, will the name of the child will be given over there in the instructions? Okay.
Yeah, most probably.
Yes, in that case, I have to.
Yeah,
that's
then
I did not, because the name of the child was not given.
Yeah.
So I assume that I already know, and she knows that a meeting is going to be conducted. Okay.
No, because she went there to maybe see the child, and she didn't know that you are representing consultant who is in the OT operating on the patient. So you have to make sure that who that person is. Could be even child's aunt, could be child's stepmother or someone, because the condition is like this, or maybe she could be someone else. So you have to confirm the relation of the relative first, and then the way you begin, it was very nice. Once you offered, after you told a little bit, then you said, okay, is that okay? Do you need someone by your side? Maybe before, when the mother is asking you, where is my child? Can I see my child? Like she's terrified, frustrated, anxious. She's all gone. So at that time, maybe you can say, okay, yes, I'm here to help you. Can you please sit down? Can you calm yourself down? Can I get a glass of water for you? Would you be needing a paper? Maybe she's crying as well. So after she has been seated and relaxed and calm, okay, now that you have take a deep breath, maybe you can even tell her a little bit extra sentences to make sure that she relaxes down. And then you can, okay, you begin very well. It was very calm. It was very focused. As I said, it was to the point, and it was very well structured. But these little things we can improve. At the end.
Yes, ma'am. Thank you so much.
At the end, when you said, okay, let me summarize what I told you. No, you're not there to tell someone anything. You're there to discuss. Or what can I discuss? Can I summarize what we have been discussing? So it's just a choice of little words, which makes a great difference. So maybe you can change the vocabulary a little bit. This will help you. It's just like when if you're cooking something and you add some additives. So it's some additives. So it gives an extra taste. So the people who are trying it, who are tasting it, they give you more remarks. That,
so ma'am, could you just please tell that again? What are the words that to be chosen while we summarize the things?
If you're discussing it with the patient, so you can say, okay, can I summarize what we have been discussing so far? So
okay,
so that if you have any other question, you can ask me later on. So by that, saying by that, you can summarize it. If it's a consultant for whom you have to, on the call, you have to summarize it, then you can say, all right, let me summarize what the instructions that you have given me. So the word would change because of the scenario, because of the position you are in, because there he is the boss, consultant is the boss, and you're on the taking end, you're taking instruction. So you have to make sure that you are taking instruction, and you have to like repeat it as well. Can I summarize the instructions that you have given me? That is call to the vascular surgeon, etc. So here you are in charge because you are superior to the patient's relative. So you can say, can I summarize what we have discussed so far, or what we have been discussing? So like it's depending upon your personality.
Yeah, I liked these words that so that you can ask me any question if still left with you.
Yeah,
that's a good idea.
Good, thank you.
Thank you.
Started your timer, and here is your question. Yes. So if you have
Okay.
read and understood, considering it clinical examination station, kindly begin.
I would enter the room.
Yes.
I will wash my hands.
Yes.
I will introduce myself. I am one of the candidates for this exam.
Yes.
May I examine you? Can I confirm your name and age, sir?
It's okay. It's Samantha, 56 years old.
Okay, I would like to examine your right jaw, which would include my examining you from inspecting your right jaw and your left jaw. It also include your opening your mouth and also my going to your back to examine you, sir. So can I go ahead, sir?
Yes. Yes, please.
I will want to expose my patient. I'll remove any, if he's having a hat or any wearing any object, I would like to expose him to the neck. Then first, I will start with my inspection. Then my inspection, I'll check for the 6X. I'll check for the site, the shape, the symmetry of the contralateral side. I'll also check for the overlying skin and any visible scars on the ipsilateral side. Then I'll also check for the contralateral side. On inspection, I will assess for features of facial nerve involvement, which would include, I will tell my patient to raise his eyebrow. I'll also tell him to shut his eyes, again, resistance, to also blow out his cheeks. Then I will tell him to open his mouth, whereby I will inspect the opening of the Stenson dot, which is at the upper second molar. Then I also inspect the contralateral left side. Then I will then go to the back of my patient, whereby I will have to palpate the lump. I will check for the site, the surface. Then I also tell my patients to clench his teeth, whereby I check for the fixity of the lump to the underlying structures. Then I will do at the back of the patient, when I'm behind the patient, I will palpate the lymph node, which would include the submental, the submandibular, the preauricular lymph nodes, the postauricular lymph nodes that I will palpate. Then I also palpate the Stenson's dots. Then I'll do a bimanual examination of the ipsilateral jaw. Then I will then go and palpate the contralateral left jaw. Then having done that, I will come to the front of the patient, and then I will thank my patient.
Yes.
And I will
Can
wash
you
my hands.
please explain the bimanual examination? How would you do
the
that?
bimanual,
Yes.
the bimanual examination, I will use with my hands will be gloved. Then I will use one of my fingers
Your
inside
hands
the
will be
mouth of the
gloved.
patient.
Yes. Yes. Yes.
Yes, I'll use one of the index finger of
Yes.
one hand and then put inside the mouth, and then I'll put the other hand
Yes.
outside, on the outside, while I do a palpation at the same time.
Yes. You'll do it
So,
on one side and then on the other side. Yes, both.
Yes, I will also do it on the other side now.
Okay, good.
Then, when I've finished examining my patient, then I will summarize my findings. I examined a...
Yes, wait. I'll tell you when Bell will go. Okay, maybe we can because you still have 2 minutes, so we can maybe discuss some of the things that 2 minutes you still have. So some of the things that you could maybe examine when you're palpating the patient. So maybe you can also examine, because once you're palpating, you don't have gloves on, right? So you're maybe with the back of the hand checking temperature and if there is any tenderness, if there is any warmth, anything, so that you're also palpating or making sure there isn't anything. Anything else?
Yes. I also check for the facial nerve, which I said.
Yeah, facial nerve that you checked before. Okay, so maybe now you can summarize your case. your examination?
I examined a man
Yes,
with
56
an
years old,
ipsilateral with a 56-year-old man with an ipsilateral swelling, which is in the front and below the right ear.
Yes.
The swelling is firm, is painless, has no differential warmth. It was not attached to overlying skin nor underlying structures. There was no involvement of the facial nerve. There was no differential warmth, and there were no palpable lymph nodes.
Yes. And the size of the lump was maybe a pea size?
The swelling was about 3 cm by 4 cm.
Very good. Okay. So what are your differential diagnosis for this patient?
Yeah, my differential diagnosis for this patient is a benign neoplasm, most likely a pleomorphic adenoma.
Okay, and second, third, and fourth. I need fourth, please.
Okay, my second differential will be an inflammatory condition.
Yes.
My third differential will be an infective condition, but the patient doesn't have positive differential warts or tenderness. Then my fourth differential will be a malignant neoplasm.
Very good. Yes. Okay. Can you please tell me how would you confirm your diagnosis?
Having examined my patients, I will want to perform some investigations, which would include a CT scan, and then the MRI, which will help me to assess the extent of the local or bony or perineural invasion. I also want to do an ultrasound scan. Then I also want to do a fine needle aspiration cytology.
All right. Okay. In your opinion, how many fine needle aspiration cytology should be done before you'll make your diagnosis?
I can do one fine needle aspiration cytology.
One is not enough, at least 2 to 3. Okay, what are the treatment options that you can offer this patient?
I will discuss this patient's case in the multidisciplinary team.
Very good.
The treatment option which I will give my index patient would be a superficial parotidectomy.
Yes. First, you said right, you'll discuss it with MDT. Second, treatment option will be depending upon the cause. If the cause is like your first benign neoplasm, then you'll do what you are telling me now.
Yes, ma'am. Yes, ma'am.
Good. So just few seconds are left. 7, 3. Right, thank you.
Yeah, thank you, ma'am.
Here is your question. Right, so if you have read and understood considering it critical care scenario, kindly tell me how would you manage this patient?
This being a serious patient with the potassium weight 8.5 and body temperature is 26.4, I will manage the patient according to protocol. I will start with the ABCD approach.
Yes.
I will look for the airway and then check for the breathing. Then in circulation, I will take 2 large white bore cannulas and will send the samples for investigations and start her fluid with the fluid resuscitation.
Yes.
And
Yes.
then I will go to the stability limitation by checking her GCS and then exposure.
All right. How do you plan to correct patient's potassium?
I will start with calcium gluconate, and then I will start with insulin plus glucose, and then I can also give sodium bicarbonate.
How much insulin would you recommend?
5 to 10 ml per over 15 to 20 minutes.
All right. Okay. Considering the patient's condition, why do you think patient is presenting with hypokalemia?
Because of the hypothermia will lead to muscle breakdown and that can cause hypokalemia.
Okay, what's its association of hypokalemia with metabolic acidosis?
Hypokalemia causes metabolic alkalosis.
Yes, how? How does it contribute? Can you explain the mechanism behind it, please? Okay, you said hypothermia. Can you define hypothermia, please? When would you consider or recommend that now this body temperature is categorized as hypothermia?
When the core body temperature is less than 36 degrees Celsius.
Or less than 35, because 36, okay, the less than that is yes. Can you, can you classify hypothermia?
Mild, moderate, severe.
Very good. What would be the severe hypothermia? What is the lowest range?
Less than 28.
Okay. Can you please tell me how can you suggest that core body temperature can be measured?
It can be measured from the oral
Very good.
impanding membrane,
Yes.
rectal, or esophageal.
Yes, good. Can you suggest few reasons or few causes of hypothermia by which patient can present in your ER?
Causes
yes, of hypothermia. As a surgeon in a accident and emergency, patient can be brought in with hypothermia. Can you mention few causes?
In case of massive bleeding,
okay,
or when a massive blood transfusion is done, it can also cause hypothermia.
Yes.
Or there is excessive blood loss due to hypovolemic shock.
Very good.
Or it can be abdominal aortic rupture.
Yeah, when you are operating and organs are exposed for too long. Okay, can you, all right, you already told me what kind of, okay, this in this case, it was cold environment which has led to hypothermia. So can you please tell me, if you don't get to manage your patient on time, what are the complications that you should look out for?
It can cause cardiac arrhythmias or myocardial ischemia or coagulopathies.
Yes. And other organs?
In respiratory, it can lead to increased pulmonary vascular resistance. Yes. And decrease the ventilation drive. And in renal, it can decrease renal blood flow. And in cardiac, it can cause
cardiac. You told me. Can you tell me hematological?
In GI, hematological, it will decrease the function of platelets and increase fibrosis. And yes. In GIT, it will lead to paralytic ileus, that is decreasing the gut motility. And it will also reduce the basal metabolic rate of the body.
Yes.
And
can you please tell me Yes. What are the risk factors for hypothermia, please? How
Risk
can you,
factors,
yes, reduce the risk factors for hypothermia?
risk factors can be major surgery, or it can be due to anesthesia.
No,
Or,
how the risk factors can be reduced? You're operating on a patient, so how would
Yes.
you make sure patient does not go into hypothermia? So you'll give warm irrigation,
warm saline.
IV fluids. What else?
We can use blankets, that is bear hugger system, and we should avoid prolonged surgery and minimize the blood loss. And we should maintain the theater temperature to around 21
Yes.
degrees Celsius.
Yes, and more thoughtful. You'll have less exposure. You'll try your best not
Yes,
to
ma'am.
expose the patient too
For
much.
the patient. Yes.
Yes.
Yes, ma'am.
And all right, you told me. All right, okay. Kindly tell me what are the mechanisms by which humans can generate heat or combat temperature or hypothermia?
By the muscle activity.
Can you please help me understand what is conduction and what is convection?
Conduction is a direct transfer of heat to the operating table and fluids, and convection is warming of the cool air, and evaporation is during surgery when the abdomen is open, and radiation is by when the heat is transmitted to the surrounding instruments in the theater.
Okay. Right. Where would you plan to manage this patient, and who would you
I
involve?
will manage the patient in HDU.
ITU, yes. And who would you involve in the management of this patient?
I will involve the ITU consultant, the
And?
hematologist consultant, and
Yes.
the anesthesiologist consultant,
And
the surgeon.
okay, and maybe nephrologist as well. Good. Yes, good. Yes, thank you.
Thank you, ma'am.
Here is your question. Right. If you have read and understood, considering this surgical pathology patient, kindly tell me what are the differential diagnoses that you would consider for this patient?
My differential diagnosis will be either it can be basal cell carcinoma, or it can be a malignant melanoma, or it can be a TB, or it can be a solar keratosis or acne keratosis.
Okay, can you please help me and describe the lesion patient has? By the way, your differentials were not correct. We'll discuss that later. Okay, can you please explain the lesion that you're looking at, please, here on the right hand side?
Yeah, it's an ulcerated lesion involving the left side of the nose,
okay,
with surrounding surrounding high vascularization.
Yes.
With central scab.
Okay. Can you please tell me how would you confirm your diagnosis?
I would like to confirm my the diagnosis by doing first either a scrape, first taking a excision and a biopsy, ma'am, for the same thing.
Okay. Any other?
Or I
Yes,
can send
please.
for immunohistochemistry or doing a most micrographic surgery and then for immunohistochemistry or genetic mutations.
Okay. Right. Can you please tell me, considering your differential diagnosis, how would you know if it's, what are the differences if it's basal cell carcinoma or is it squamous cell carcinoma?
Ma'am, basal cell carcinoma will be a papule type with central ulceration can be there with surrounding vascularization due to epidermal venule formation, whereas squamous cell carcinoma can be a reddish lesion, or it can be a keratotic lesion.
This
with a
is
disfigurement.
one difference. Second and third, please, quickly.
Second will be either malignant melanoma, ma'am.
No. Difference between these two, can you have just told me one
okay,
difference? If you can tell me 2 or 3 more differences.
Differences.
Yes,
Basal cell carcinoma is a slow growing, it's an indolent, and it involves only the locally distinctive lesions, whereas squamous cell carcinoma, it is a highly malignant and it can metastasize and occurring in the squamous cell carcinoma arises from the upper and middle layers of the epidermis, whereas
okay,
basal
if
cell
we
carcinoma
are,
arises from
yes, if we are discussing metastasis, how does basal cell carcinoma metastasize as compared to squamous cell carcinoma, please?
Ma'am, basal cell carcinoma less likely to metastasize. It is mainly locally disfigurement
Locally.
causing. Yeah.
It metastasizes locally. And squamous cell carcinoma?
Ma'am, squamous cell carcinoma, they can metastasize either via lymphatic or hematogenous, both, ma'am. Lymphatic mainly either because of lymphatic permeation and embolization from the draining lymph nodes, or it can spread into the surrounding vascular structures also.
Can you please tell me what is the mechanism behind this metastasis?
Ma'am, basically, wherever the malignancy is there, it starts inducing the vascular endothelial growth factors. Because of this, there will be a new vessel generation within the draining lymph nodes of the particular organ. So these will get the draining malignant cells will get infiltrated into these new vessels, resulting in the permeation, and they'll get embolized into some distant structures.
Yes, those 5 steps. Okay. Right, okay. Can you please tell me what are the treatment options? Okay, you've done the diagnosis. Now, what are the treatment options that you can offer to this patient?
Ma'am, my treatment options would be either it can be surgical, it can be a radiotherapy, or it can be a topical. Either surgically, we can either do a most micrographic tangential excision of the tumor and look for the deep margin involvement, or we can do a excision followed by graft formation or a flap formation, or we can do a curettage and dissection. Then we can perform either using a radiotherapy, and topically we can use 5% imiquimod or fluorouracil. Along with that, we can give topical photodynamic therapy, in which gamma aminolevulinic acid will be applied, and it will become a photosensitive protoporphyrin 9, and it will be destructive when exposed to sunlight or UV rays. Sorry.
All right. What measures would you take to prevent recurrence of the deep margins involvement during surgery?
Ma'am, one thing I'll either take the FNAC and mainly other is most micrographic surgery, then frozen section biopsy.
Yes,
frozen section.
Okay, this patient had a gap here, and you wanted to fill the gap with the graft. What kind of grafts are available for this patient, or you can suggest?
For this, either we can do a flap rather than a graft. It's a nasolabial rotational flap we can use for this for this condition.
Yes. What if you have used this flap and this is not healing? Instead, you realize that there is infection. So what kind of infection are common? Post-operatively? Yes.
The wound infection can be post-operatively because of gram-positive or staph aureus infection.
Staph aureus, yes. So what would you do in that condition? You'll
Ma'am,
take the
I will,
wound swab
I-
and then, yes.
I'll initially take a wound swab.
Yes.
Then I'll keep on antibiotics as per the wound culture sensitivity, and I look
Yes.
for whether the graft uptake or whether it is complete failure. Then I'll go plan for a debridement of the area, ma'am.
Okay, right. The report has come back, and you realize the wound is infected with MRSA, methicillin resistant Staphylococcus aureus. What would be your next management option?
Ma'am, if it's a MRSA, I would treat either it is an outpatient or it is inpatient. If it's an outpatient, we can give with an oral antibiotics with mainly clindamycin and linezolid. Where if it is inpatient, we have to give with an IV antibiotics for 1 to 2 weeks duration. Same, the drugs would be same. The linezolid 600 mg twice daily or clindamycin 600 mg IV. Or we can also apply mainly vancomycin targeted dose for a week, 1 or 2 weeks. Along with that, we can add daptomycin or telavancin.
Okay, the patient, you've given the medications, and then patient after 6 months returns back and has lymph node swelling, right? What would you
Yes.
do then? How would you
If
interpret?
patient, ma'am, first I would do a local imaging for that lymph node. After that, I would like to plan for an FNAC. Then I'll see what is the FNAC report. Based upon that, I'll proceed.
What would be your
I'll think on a
What would you
background of
suspect?
malignancy. I'll think it's a metastatic recurrent lymph node.
good? Okay, now if you can, time is gone. If you want me, I can thank you. Stop here and we can discuss. Yes, started your timer, and here is your question. Right, so if you have read and understood, considering it history taking station, kindly begin.
Okay, while entering, I'll clean my hands.
Yes.
Hello, good evening. My name is Dr. Prabjit Singh. I'm one of the surgical doctor here. May I confirm your name and age?
I'm Smith. I'm 56-year-old male.
Nice to meet you, Mr. Smith. How can I help you today?
Doctor, I am having difficulty in passing urine from last 5 months, and I have noticed for last 5 weeks, and I have noticed that blood is coming while I pass urine.
I'm so sorry to know that. And could you tell me a little bit more about it? When it started 5 weeks ago, did it start suddenly, or did you find that this bleeding is coming gradually? It's increasing.
Yeah, doctor, I have seen it is frequent. The frequency of blood coming in my urine has been increased since 5 weeks, and it is troubling me a lot. I am feeling tired throughout the day these days.
So sorry to know that. Okay, could you tell me more about it? Is there any change during the daytime?
No, doctor, there is nothing like that.
Okay, and is there any pain while passing urine?
Yeah, doctor, I have occasionally now having a pain in my lower part of my body, around my private portion.
Is it every time you pass urine?
Occasionally, doctor. These days, earlier it was not there. Now it was present.
And when did you find this pain for the first time?
Doctor, the pain is for last 2 days only.
Okay, I'm so sorry. Right. And okay, I'll ask you a few more questions regarding your pain. So as you said, it's in lower part. Do it goes anywhere else?
No, doctor.
What kind of pain is it? Could you describe that?
Yeah,
Is it
doctor.
dull?
It's sometimes coming up. It's sometimes going down. It's like that, coming up, going down.
Okay. Anything that increases this pain?
Doctor, while I pass urine, the pain increases. This is what I have noticed.
And anything which improves that?
No, doctor, I don't feel like that. It is present. It is coming up. It is going.
Okay. And on a scale of 0 to 10, where 0 is minimal and 10 is maximum, how would you rate your pain?
Doctor, I could rate it to 7.
I'm so sorry that you are going through this much of pain. Okay. And what about your blood in urine? Is it a fresh blood, like a red, or is it a black kind of blood in urine?
No, doctor, it looks like a fresh thing because it is bright red.
Okay. And is it related to your urine stream? Do it comes while starting your urination or towards the end, or is it present the whole time?
Doctor, it is present throughout the whole stream.
Okay. Do you find any blood clots in urine?
No, doctor.
Okay. By any chance, have you started taking beetroot in your diet
No, doctor.
recently?
No, doctor. No, doctor.
Okay. Do you feel any weight loss recently?
Yeah, doctor, but I haven't checked it. But I feel like my clothes are loose these days.
Okay. And what about your appetite?
I feel exhausted throughout my days. I'm not feeling to eat anything.
I'm so sorry to hear that. And tell me, did you travel recently anywhere?
No, doctor.
Are you feeling ill or having fever or chills or rigors?
Yeah, doctor. I told you, I am feeling so tired, exhausted throughout the day. I'm not having any fever and all, but I feel exhausted.
Okay. Any pain which is going from your tummy to your back?
No, doctor.
Did you hurt yourself in the lower part of your tummy?
No, doctor.
The private part? Okay.
No, doctor.
Is there okay. Do you find any change in your frequency of urination? Has it increased? The times you are going to the loo for urination,
doctor.
has it increased? Okay.
No, doctor.
Is there any increase in number of times you're going at night time?
No, doctor. I normally wake up 1 or twice during night to pass urine.
Okay. And is there any weakness in the stream of urine?
No, doctor.
Okay. And I would like to ask you a few other questions which are related to your personal history. Do you smoke or do you drink alcohol?
Yeah, doctor. I am a smoker. I normally take 7 to 8 cigars a day.
Okay. And any other condition you have, medical condition for which you are seeing the GP for?
Yeah, doctor. I am a hypertensive. My GP has given me medication and he told me I am under control.
And do you know the name of the medication?
No, doctor, I don't know.
Okay, it's okay. And any drug allergy you are having?
No, doctor, I am not allergic to any drugs.
Anybody in family having similar problem or in the past having similar? Okay, right. And what do you do for living?
I am work in a factory, doctor. I'm a factory worker.
And what kind of factory, if that's okay to tell?
Yeah, it's we make a wooden furnitures.
Okay, thank you so much. I'll come back to you,
Can you
later.
summarize your history now,
Yeah,
please?
in order to complete my history, I would like to ask about the concerns and expectations and the patient's knowledge about the condition, if the patient knows what the reason is. And also in the history, I would like to ask the systemic examination. So today I examined 56-year-old gentleman who is a factory worker. And he presented with the history of blood in urine, basically hematuria for 5 weeks, with the pain in the loin region for 2 days. He's a smoker and hypertensive and works in a dye factory. and he has lost weight over the time, which patient has not measured otherwise. The urination is associated with pain, so it's a dysuria. Patient has not traveled anywhere. So my main differential from this history is a ureteric stone.
Okay. What are the other
but my other
differential-
differentials could be CA bladder, and it could also be due to BPH, benign prostatic hyperplasia, or trauma to the groin area, or it could also be bleeding diathesis, which I did not ask for, but I should have. And
how do you intend to manage this patient?
So I would like to do a full clinical examination of the patient of abdominal and pelvic region, and send blood tests for full blood counts, RBCs. I will also take the urine for spot and cytology test for malignancy. And per rectal examination can be done for checking the BPH and PSA levels for CA of the prostate.
CA, okay. What are the treatment options that you can offer this patient?
Yeah, I'll also get a CT scan of the pelvic region. So if it comes out to be basically, and ultrasound, so it comes out to be a ureteric stone, we have to go for the sizing of the stone. If it's small in size, so conservative management can be done for less than 5 mm. But if it's larger than that, we have to either go for DJ stenting or retrieval through scopy, and so these are the treatment managements which we can do for a ureteric stone.
Yes, which was your primary diagnosis. All right, good, thank you.
Thank you.
Here is your question. Okay, time. And okay, if you have read and understood considering it's surgical and not patient, kindly tell me if you can, what organ you're looking at.
This specimen of liver.
Yes. Can you please identify the structures which are circled in red? Can you identify 9?
Is gallbladder.
Good. 5, please.
5 common hepatic duct.
20, please.
20 portal vein.
11.
Hepatic artery.
21, please.
Quadrate lobe.
17, please.
Ligamentum teres hepatis.
2, please.
Caudate lobe.
13, please.
Inferior vena cava.
25, please.
This is right leaf of cornea ligament.
15, please.
Left leaf of cornea ligament. Left cornea ligament.
Can you please tell me how would you divide the liver?
It can be divided anatomically by the anteriorly by the falciform ligament and posteriorly by the ligamentum teres hepatis and ligamentum venosum.
Yes.
And it can be divided physiologically by the right and left lobe by the cholecysto vena cava line, by the gallbladder and inferior vena cava. This this line.
Can you please tell me what is porta hepatis?
Porta hepatis is the region where the common hepatic duct and hepatic artery, portal vein, all
Can you please tell me these structures in order, how they are present in the porta hepatis in the right the right relation?
On the right lateral side, there is the common hepatic duct, and then medially is the hepatic artery, and posteriorly is the portal vein.
Very good. Can you please tell me the ligaments which support the liver?
Calciform ligament, which connects the anterior surface of liver with the anterior abdominal wall, and there is corner ligament, right and left corner ligament, and
which connects the liver to the diaphragm.
liver to the diaphragm.
Yes, and then there are
hepatic vein, which also supports
right
liver.
and left triangular ligaments. They also connect the liver to the diaphragm. What about the lesser omentum? It connects the liver and
lesser curvature of the stomach and first part of the urine.
Very good. Okay. Can you please tell me the blood supply of the liver?
Blood supply liver from the two sources, from majority from the portal vein, 60 to 70%, and
good.
From the hepatic artery, 20 to 30%.
Yes. Hepatic artery happens to supply another very important organ. Can you please tell me which one?
It's there is a branch of the gastroduodenal artery which
supplies stomach.
Supplies.
Yes. Okay. Can you please tell me the bare area of the liver? Which one was that you told me? Can you identify again and tell me why does it call the bare area?
Number one.
Okay.
Bare area.
Because
it is entirely non-peritoneal, so it's called the bare area of liver.
And what comes in the relation of the bare area? Okay, can you please tell me what are the parts of the gallbladder?
There is 3 parts: neck, fundus, and the neck, fundus, and the body of gallbladder.
Okay, can you please tell me the surface marking of the gallbladder, please?
Gallbladder situated in the there is in the transpyloric vein, from which is the transpyloric vein which can merge with the right costal margin, which and at this point the gallbladder is situated.
It's at the angle between the 9th costal cartilage and the lateral margin of the rectus sheath, because you would be given, if it's because that's what it was happening, they'll give you a pen and they'll give you a subject and you would have to mark it, or you would have to tell where it is located. Okay, can you please tell me that if a patient is suffering from cholecystitis, why would a patient present with the pain in the tip of the shoulder?
In the cholecystitis, there is inflammation of the gallbladder, which causes irritation of the diaphragm, and diaphragm supplied by the phrenic nerve C345, which has the same route with the supraclavicular nerve. So there is same pathway. So there is pain in the shoulder.
Yes, that's why you feel pain in the tip of the shoulder. Okay. Yes, if you can please explain what you are looking at, and if you can identify the structures as well, please.
This is the image of, I think, MRCP.
Okay. And if you can identify A to E, please.
A is gallbladder, and B is right hepatic duct, C is left hepatic duct, and E is common bile duct, and B.
What are the conditions of the What are the hepatic conditions in which this imaging can be asked for or can be beneficial?
MRCP is beneficial in case of if there is stone in the biliary system, or
Okay.
there is to diagnose the stricture, or is in bile duct injury, and to diagnose the colorectal cyst.
Yes. Is there any other imaging better than this one which can be done?
RCP can be done,
Yes.
which has the both diagnostic and therapeutic benefit.
Very good. Yes. Any other imaging which can be done? Can you please tell me the blood supply of the gallbladder, please?
Gallbladder is supplied by the cystic artery, which is a branch of the right hepatic artery.
Good. Yes, very good. Well on time. Thank you.
Thank you.
Thank you. So started your timer, and here is your question. Right, so if you have read and understood, considering it is taking station, kindly begin.
Okay. First of all, I do hand wash, and then we start my history. Hello, good morning.
Hello, yes, please.
Hello, good morning. I am Dr. Catherine, one of the surgical doctors there. May I confirm your name and age, please?
My name is Mr. John, 40 years age, 55 years age.
I'm nice to meet you, Mr. John. Today I have asked to talk to you about the problem you're having. Is that all right?
Yes, please.
What has caused you to come and see me today?
I have difficulty in swallowing.
I'm so sorry to hear that, Mr. John. Let's see what we can do for you.
Yes. So much disturbance is there. I can't hear anything. Hello?
Yeah, it's maybe
I
her
can't
mic.
appreciate it now. So much disturbance is there.
Are you comfortable in your position?
Dr. Catherine,
Hello?
can you please fix your mic? Echo is coming with your voice.
Are you comfortable in this position, Mr. John? Can you hear me?
Yes. Voice is not clear, but that's why Dr.
Background lot
cannot.
of noise is coming now. Can't hear.
Yeah.
Can you hear me?
Yes, now better. Yes.
Okay. Can we proceed now?
Yes, please. Continue.
Okay. So, Mr. John, are you comfortable in your position?
Yes.
Is it okay if I note down some notes from your history? Is it okay to you?
Yes. Continue. Yes.
Okay. So, Mr. John, for how long you are suffering from this problem?
On and off from last 10 months.
Okay, I'm so sorry to hear that. How do you start?
It started off with the difficulty with the solid food, now even with the liquid.
I'm so sorry to hear that.
Yes,
That's
all the time.
okay. Is it painful?
It bothers a lot. Yes.
Right. So, have you noticed that your was foot stuck over your sock?
Your voice is gone again. Can you bring mic closer to you?
Have you ever noticed that your foot stuck over your throat?
Yes, yes, always.
All right.
Yes, it does.
Have you noticed any bad smell or a bad smell ever?
Yes, it does.
Bad smell.
Yes, please.
Okay. Any swallowing, any gargling after swallowing?
No, not always.
Right. Any acidic taste in your mouth or in your mouth?
Yes, sometimes. Yes.
All right. Any lump or lump in your throat or any side of your body?
No, not lump. No.
Okay. So, Mr. John, how's your appetite been?
My appetite has been bad. I've lost a lot of weight now.
I'm so sorry to hear that. Do you have any other medical conditions like high blood pressure or high blood sugar, or ever had any surgeries?
No, none of
Okay.
these. Yes.
Okay. Anyone in your family suffering from the same kind of problems?
No, none of them.
Uh,
Yes.
do you have any allergic conditions against any medications or food?
No, no
Yeah.
allergy to anything.
Okay. May I ask a personal question if you don't mind?
Yes, please.
Whom do you live with?
I live alone.
Okay. What do you do for living?
I'm a salesperson.
All right. Do you smoke?
Yes, sometimes.
Okay. Do you drink alcohol?
Yes, casually.
All right. Are you well immunized?
Sorry.
Are you well immunized?
I'm sorry, I cannot hear.
May I ask some other question regarding to your health condition?
Yes, please. Sure.
Okay. Have you recently gone through fever or cough or wheeze?
No, not in particular.
Okay. Any chest pain or palpitations?
No.
Okay. Any weakness in your any side of your body?
No. Can you summarize your history now, please?
Okay. My patient, Mr. John, 54-year-old, non-hypertensive, came with the difficulty in swallowing for the last 10 months, which is for both solid and liquid, and his appetite is poor appetite and lost his weight, and he's a smoker and alcoholic, and there is no signs, no history of no positive family history. And according to his history, my top differential is dysphagia due to carcinoma esophagus.
Okay. What are the other differential diagnoses that you'll consider?
My other differentials is achalasia cardia, myasthenia gravis, and gastroesophageal reflux disease.
How would you confirm your diagnosis?
Hello.
What investigations would you ask for?
Okay.
Yes, what investigations?
I'll do a full blood count and urea electrolytes, liver function test, and get esophageal manometry and chest X-ray and brain story, and endoscopic biopsy and esophageal insulin and ultrasound.
How would you treat your patient?
I would like to treat the patient according to the rating and severity, and I consult with the medical team.
Okay, good. Thank
There is
you.
a